Welcome to the Deep Dive. We're here to break down complex topics so you can operate with expert-level insight. Today, we're tackling something huge, really a defining challenge in modern healthcare, mastering the perioperative journey for geriatric patients. And the starting point, well, it's this massive demographic shift. Just think about it. Over the last 50 years, a 300% increase globally in people aged 65 plus.
It's a staggering number, truly. And it translates directly into this exponential rise in demand for surgery, and critically, for the kind of specialized anesthetic management we need to talk about.
Right.
If you look just at the U.S., projections show 73 million people over 65 by 2030. And then it jumps again, maybe 83 million by 2050. That's almost double what we were estimating back in, 2012.
Wow. And it's not just the total number, is it? There's that specific group, the oldest old, those 85 and up.
Exactly. That group is set to triple, which puts the U.S. in a challenging spot. We'll have the largest population of the oldest old among developed nations.
And this isn't some far-off future thing. It's happening now.
It's absolutely happening now. And becoming more diverse, too. Projections show Black, Asian, Hispanic populations over 65 doubling, even tripling. It changes the whole picture of care delivery.
So, okay, we use older adults, say 65 plus, as a working definition. But the real mission here, what someone striving for that elite level needs to grasp, it's moving past just the number of birthdays, right?
Completely beyond chronological age. Our focus has to be on understanding and actually quantifying biologic age. What's their functional status? Because, the anatomical, the physiological, the pharmacological changes that come with aging, they hit every single step of the perioperative path. And they create these unique traps if you're not prepared. So yeah, our goal today is to equip you to see the patient's biological reality, not just their date of birth.
Okay, let's ground this demographic surge in the clinic. This growing population, they use healthcare services way more intensely than younger groups, right?
Oh, profoundly higher rates. The national data is crystal clear. Over 65s. Significantly higher rates of hospital stays, surgeries, non-surgical procedures, you name it. And the oldest old are really the most resource-intensive group within that population.
So this high use basically guarantees that surgical risk is something we have to face head-on proactively.
Absolutely. Which brings us right to the preoperative assessment. And here's the critical insight. Your standard run-of-the-mill pre-op check. It's just not enough for these patients.
Why specifically? What makes it insufficient?
Two big things. One, this progressive decline in their functional reserve. And two, the sheer prevalence of multiple health conditions, what we call multimorbidity, which, often translates to a higher ASA physical status class.
So if that declining reserve is the patient's core vulnerability, what are the big bad outcomes we're trying to head off during surgery and recovery?
That loss of reserve directly increases the risk for major, potentially fatal complications. We're talking primarily cardiac issues, pulmonary problems, and neurologic dysfunction like delirium. When you dig into the data on poor outcomes in the elderly, three factors really jump out. First, needing emergency surgery, that's a huge risk multiplier. Second, just the raw number of other diseases the patient has. And third, the type and sheer scale of the operation itself.
Okay. So if you want to operate at that elite level, you have to look past the standard H&P. You need a better framework, something to actually measure that reserve tank.
Precisely. And that's exactly where the best practice guidelines, from the American College of Surgeons, NSQIP, and the American Geriatrics Society, the AGS, that's where they become absolutely essential. Mandatory, really.
What are those key assessment areas they demand? The things that separate just standard care from real mastery?
This is the bedrock of what we call comprehensive geriatric assessment. It means using specific screening tools, looking at neurocognitive aspects, and their physical function. This isn't just nice to have, it's vital for quality care. So the categories are clear. You must screen their cognitive ability. You have to formally establish their decision-making capacity. You need to assess for depression, and importantly, calculate their specific risk for postoperative delirium, or POD.
Okay, so that covers the brain side. What about physical resilience?
Right. Then you quantify their physical state. You assess for frailty. You get detailed functional status. What can they do? Activities of daily living, instrumental activities of daily living. And finally, a really rigorous review of all their medications, polypharmacy. Often we use the Beers criteria list to guide that review, identifying potentially inappropriate drugs.
That completely reframes the pre-op visit, doesn't it? It's not just ticking off diseases. It's about getting such a precise baseline of their function that you know exactly what they've got left. What's their margin?
Exactly right. We often call it the margin of reserve. And aging just progressively shrinks that margin. Think of it maybe like driving a car that only ever has a quarter tank of gas.
Mhm.
Under normal conditions, flat road, they're okay maintaining homeostasis. But hit one unexpected hill, the stress of surgery, maybe some blood loss and infection, and boom, they stall out. They just can't cope or get back to balance. The comprehensive assessment is designed to see that hill coming and prevent the stall.
All right, let's dive into the cardiovascular system because, man, this seems like where things can go wrong really fast in older surgical patients. We hear stiffer. Mechanistically, what are the key structural functional changes in the heart and vessels?
Yeah, stiffer is the word. Reduced compliance is the core issue right across the board. The heart muscle itself, the vascular system, they just become less pliable, less elastic. Structurally, this increases the resistance the heart pumps against the afterload. This leads to that progressive rise in systolic blood pressure. And over time, that forces the left ventricle muscle to thicken up. It's a kind of compensation, ventricular hypertrophy. But that thickening, it's a major problem down the line.
And that ventricular thickening, that hypertrophy, leads straight to maybe the most critical vulnerability, diastolic dysfunction. Can you unpack that for us? Why is it so crucial?
It is absolutely the crucial consequence. The thickened ventricle, combined with slower, less efficient relaxation of the heart muscle between beats, makes the ventricle stiff. It resists passive filling with blood. So what happens is most of the ventricular filling gets pushed very late in the cycle during late diastole. Clinically, this makes the patient incredibly reliant on one specific thing, a strong, synchronized contraction of the atria, that atrial kick.
The atrial kick.
That kick might be responsible for up to 40% of the blood volume in the ventricle right before it pumps. So if they lose that atrial contribution, let's say they flip into acute AFib, their preload, the amount of blood filling the heart just plummets. And so does their cardiac output. It's often instantaneous and really dangerous.
Okay, now here's that physiological puzzle, the paradox that professionals really need to get. Older adults often have higher levels of circulating stress hormones, catecholamines.
Right. Biochemically, they seem revved up.
But their organs, especially the heart, show decreased responsiveness to those hormones. What's going on there? What does it mean practically?
It's a classic case of receptor downregulation, maybe some functional decoupling. Basically, the body's sending out this loud alarm signal, but the adrenergic receptors on the heart muscle are, well, less sensitive, almost deaf to the signal. And the clinical impact is huge. It defines our management strategy. They have a profoundly reduced ability to crank up their heart rate or contractility when faced with major perioperative stress, like sudden blood loss, hypotension, low oxygen.
So their main coping mechanism is blunted.
Exactly. That fight-or-flight surge in heart rate, it's weakened. So trying to rescue them with drugs that primarily boost heart rate, like epinephrine, often isn't as effective as you expect, which makes managing their volume status before a crisis hits absolutely critical. Preemptive is key.
Let's break down the vascular side too, and the conduction system changes. How do they feed into this blunted response?
Okay, so arterial stiffness caused by flexible elastin being replaced by rigid collagen doesn't just cause systolic hypertension. It also creates this abnormally wide gap between systolic and diastolic pressure, a widened pulse pressure. Venous compliance also goes down, which can, maybe counterintuitively, sometimes reduce preload depending on how much volume they have on board.
Right.
But maybe most importantly, the sensitivity of the baroreceptors, those key pressure sensors in the aorta and carotid arteries, it drops significantly.
Okay, so the pressure sensors are less sensitive.
Which means when their blood pressure falls, the reflex signal to correct it is delayed or just doesn't fire strongly enough. This makes severe, prolonged drops in blood pressure much more likely, especially, during induction of anesthesia or even just changing their position on the table.
And the heart's electrical system itself gets physically worn down, leading to specific rhythm risks?
Yes, absolutely. Aging brings fibrosis, calcification, a gradual loss of the pacemaker cells in the sinoatrial node. And all this makes older patients much more prone to significant arrhythmias that mess with cardiac output. Things like atrial fibrillation, sick sinus syndrome, various types of heart block, which explains why so many older patients end up needing pacemakers or ICDs.
Okay, let's connect these physiological changes directly to anesthesia practice. You mentioned prolonged circulation times, slower blood flow from stiff vessels, lower cardiac output. How does that mess with induction timing for IV versus inhaled drugs?
This is a really key point, and it's kind of counterintuitive, a dual dynamic. Because circulation is slower, it takes longer for intravenous drugs like propofol to get from the vein where you inject it to the brain where it works.
Longer for 5E drugs.
Right, which creates a real risk of overdose if the provider pushes the drug too fast. expecting a quick effect like in a younger patient.
Hmm.
They might think the first dose wasn't enough and give more when it just hasn't arrived yet.
Okay.
Conversely, induction time with inhalation agents, the gases, is paradoxically faster.
Faster with gases. Why?
Because the reduced cardiac output means less of the gas is taken up and sort of stored in the peripheral tissues. A higher fraction gets delivered more quickly to the brain, so they go under faster with inhaled agents.
That's crucial. 5E onset delayed, inhaled onset faster. Got it. And the ever-present risk of blood pressure being all over the place, labile BP?
It's almost a given. Anesthetic agents, well, they naturally blunt sympathetic tone. Combine that with the already sluggish baroreflexes we talked about, and the patient becomes extremely sensitive to sudden drops in pressure. Hypotension is a constant threat.
So what does that force us to rely on?
Clinically, it means we become heavily dependent on the Frank-Starling mechanism. Since their heart rate can't easily increase to compensate, their cardiac output becomes highly sensitive to their volume status. Small shifts in volume can cause exaggerated swings in how much the heart fills and pumps out. The bottom line, their total cardiac reserve is significantly limited. They just don't have the compensatory power to handle major surgical stress well.
Moving towards risk assessment, the ACS NSQIP guidelines point to specific, newer tools beyond the old indices.
They do. Beyond just the standard ACE cardiac guidelines, the most recommended functional assessment tool is measuring functional capacity using metabolic equivalents, or MET-Ts. We really need to know. Can the patient climb 2 flights of stairs? Can they walk 4 blocks? That's about 4 MET-Ts. If they can't hit that 4 MET mark, their risk is significantly higher.
Okay, so MET-Ts for functional capacity. What else?
Additionally, we should be using the sophisticated interactive perioperative cardiac risk calculator. This online tool has pretty much replaced the older revised cardiac risk index. It gives a more personalized risk score based on a specific set of inputs. The type of surgery, their functional status, those MET-Ts again, their creatinine level, their ASA class, and their age. It provides a much more granular, evidence-based probability of a major cardiac event.
And the single biggest cardiac complication we're trying to prevent in this vulnerable group is?
Myocardial infarction, MI. It's still the most common serious cardiac complication after surgery, and unfortunately, it remains the #1 cause of death following non-cardiac surgery in the elderly.
Okay, so the cardiovascular system gets stiff. The respiratory system, though, that presents a different kind of picture, almost a contrast. Tell us about the structural changes in the aging chest wall.
Right, it's the chest cage itself that gets stiffer. You see calcification in the joints where the ribs meet the cartilage. You see loss of intercostal muscle mass. The diaphragm tends to flatten out a bit, and even the discs between the vertebrae lose height. All these things together decrease the compliance of the chest wall itself, making it harder to expand. And that dramatically increases the work of breathing, the WOB. They have to expend more energy just to move air in and out.
So the cage gets stiff, but the lung tissue itself, the parenchyma, actually becomes less elastic, right? How does that create problems?
Exactly. The loss of that elastic tissue recoil means the lung itself becomes overly compliant, almost floppy. This actually reduces the functional surface area of the alveoli available for gas exchange. And this impaired elasticity leads directly to worsening VHQ, mismatch, ventilation, not matching perfusion. It increases physiological dead space and shunt, and severely cuts down the efficiency of oxygen exchange at the alveolar level. Often, this is happening even before we give any anesthetic.
And this loss of elastic recoil, this floppiness, brings us to probably the most critical pulmonary concept for anesthesia in the elderly. Closing volume, or CV. Can you explain why CV is so vital to understand?
Yes, this is absolutely fundamental. That loss of elastic recoil causes the small airways, the ones without cartilage support, especially in the dependent lower parts of the lung, to narrow and collapse prematurely during exhalation. The closing volume is the specific lung volume at which these small airways start to close off and stop participating in ventilation. Now, in a young, healthy adult, their CV is normally well below their functional residual capacity, FRC. That's the amount of air left in the lungs after a normal exhale. But in the elderly, because of that reduced recoil, the CV rises steadily with age. And here's the critical point. CV exceeds FRC around age 65 when the patient is standing or sitting upright.
Okay, 65 upright.
But even more dangerously, it exceeds FRC by age 45 when the patient is lying supine.
45. So the moment they lie flat on the operating table, even before we do anything, they're already closing off airways in the lower parts of their lungs during normal breathing, causing atelectasis and mismatch.
Precisely. And then, of course, when you induce anesthesia, maybe paralyze them, start positive pressure ventilation, you only make that mismatch worse.
Mhm.
If you look at their overall lung volumes, you see the consequences. Their vital capacity, VC, inspiratory reserve volume, IRV, expiratory reserve volume, ERV, they all decrease. But the air they can't get out, the residual volume, or RV, and the FRC, they both increase. Total lung capacity at TLC stays roughly the same, though. And forced breathing tests like FVC and FEV1 are reduced because those floppy airways tend to collapse when they try to force air out quickly.
We also see issues with the brain's control over breathing.
We do. The central and peripheral chemoreceptors, the sensors that detect low oxygen or high CO2 and trigger you to breathe more, they become significantly less sensitive with age. Blunted response. This reduces their overall ventilatory drive, making older patients more prone to periods of stopping breathing, apnea, especially during emergence or recovery. Couple that with decreased protective airway reflexes like a weaker cough, less effective swallowing coordination, and the risk of airway obstruction or aspirating stomach contents goes way up, particularly risky during emergence from anesthesia.
Okay, let's shift gears to the kidneys, another system where that loss of functional reserve is really stark. What's the basic physiological reason renal function declines with age?
It's really a profound progressive atrophy of the kidney tissue itself. You see deterioration of the blood vessels within the kidney, a continuous decrease in overall renal blood flow. This leads to a decrease in total renal mass, and critically, a significant drop in the glomerular filtration rate, the GFR. We're talking maybe a 25 to 50% decline between the ages of 20 and 90. It's substantial.
A potential 50% drop in GFR. That has massive implications for handling medications. What's the single biggest practical nightmare that creates for us in the operating room?
Yeah, the absolute biggest nightmare is drug accumulation leading to overdose. That reduced GFR severely cuts down the kidney's ability to clear water-soluble drugs, hydrophilic agents. And maybe even more importantly, it reduces clearance of the water-soluble, often active metabolites of fat-soluble lipophilic drugs we give. Things stick around longer. Plus, their ability to just manage fluids is impaired. They produce less renin and aldosterone, so they're not as good at conserving sodium when they need to. Their kidneys just don't respond effectively to dehydration from other causes, making them really susceptible to both dehydration and fluid overload if we're not careful.
And here's that clinical trap, the paradox every top-tier professional needs to internalize, the creatinine paradox. Why can a patient have significantly impaired kidneys but still show a totally normal serum creatinine level?
This is a classic dangerous trap. Serum creatinine is produced from the breakdown of muscle. As people age, they inevitably lose muscle mass, that's sarcopenia. So if an elderly patient has significantly less muscle, they simply produce less creatinine day to day. Therefore, even if their actual GFR, their kidney function, has dropped by half, their serum creatinine level might look perfectly normal, maybe 1.0 milli-DL or even less.
Wow.
If you trust that serum creatinine number alone in, say, an 85-year-old frail patient, you are basically setting yourself up to overdose them with renally cleared drugs or the metabolites. You're missing the underlying impairment.
So relying only on serum creatinine is potentially hazardous? What's the mandatory standard then for assessing actual drug clearance?
The gold standard for estimating how well drugs will be cleared by the kidney is creatinine clearance. Since doing a full 24-hour urine collection is impractical preoperatively, we must calculate an estimated GFR, or eGFR, using specific formulas. The most commonly used one for reasonably healthy older adults is the Cockcroft-Gault equation. But you always have to use it with caution. It can overestimate the actual clearance in patients who are very frail, critically ill, or malnourished. So you might need further dose adjustments based on weight, age, and clinical picture, not just a calculated number.
And the downstream risks if we miss this?
The clinical risks are serious. Fluid overload, toxic accumulation of drugs or their active metabolites, dangerously prolonged drug effects, and potentially life-threatening electrolyte imbalances that can cause cardiac arrhythmias.
Okay, let's turn to the body's main processing plant, the liver. What are the key physical and functional changes there that affect how we handle drugs?
Well, the liver also shrinks with age. It undergoes this progressive atrophy, losing maybe 20 to 40% of its mass. And this seems primarily driven by a decrease in overall hepatic blood flow. This reduction in blood flow has a direct impact on drug metabolism, specifically those phase 1 reactions.
Phase 1, that's oxidation reduction.
Exactly. Oxidation reduction, hydrolysis, the reactions often handled by the cytochrome P450 enzyme system. These can be significantly reduced. Now, interestingly, phase 2 metabolism, that's conjugation, where the liver makes compounds more water-soluble for excretion. That pathway seems generally well preserved, unaffected by age alone unless there's specific liver disease.
And what about how drugs bind to proteins in the blood? We see shifts in albumin and AG. Is that a real clinical worry?
It's something to be aware of, definitely. We typically see two shifts happening at once. Serum albumin levels tend to decrease, and albumin binds acidic drugs like many opioids, benzodiazepines, propofol. At the same time, alpha-1 acid glycoprotein, or AG, which binds basic drugs like local anesthetics, often increases.
So less binding for some drugs, more for others?
Potentially. It creates this theoretical risk of having a higher concentration of the unbound, active form of highly protein-bound drugs circulating, especially if the patient's also severely malnourished, which would lower albumin even further. Now, do we routinely change doses just based on this? Often not, unless there's also significant liver disease, but it means the margin for error with dosing is smaller, you have less buffer.
Okay. Shifting to the endocrine system, the big player perioperatively is often metabolic control, especially diabetes, right?
That's certainly a major focus. With aging, we see this progressive decline in the function of the pancreatic beta cells, the ones that make insulin. This results in both decreased insulin secretion and increased resistance to insulin in the peripheral tissues. Net effect: glucose intolerance or sometimes overt type 2 diabetes.
And diabetes itself is a huge risk factor.
A major independent risk factor. It significantly bumps up the likelihood of cardiovascular complications, stroke, MI, but also infections, problems like ketoacidosis. And there's growing evidence linking long-term diabetes, say more than 10 years, with accelerated brain aging, cognitive impairment, and even Alzheimer's dementia. It affects multiple systems.
Let's talk about those fundamental shifts in body composition, losing muscle, gaining fat, changes in water content, and how they completely rewrite the rules for drug pharmacokinetics.
These shifts are absolutely foundational to geriatric anesthesia. You really have to grasp them. First, sarcopenia, that age-related loss of skeletal muscle mass. It can be up to 50% loss by age 80. This lowers the basal metabolic rate, BMR, and is a primary reason for functional decline and frailty.
Okay, less muscle, lower metabolism.
Second, body fat percentage increases, and it tends to redistribute more visceral fat, more subcutaneous abdominal fat. Third, total body water and overall blood volume significantly decrease. We're talking maybe a 20 to 30% drop by age 75.
Less muscle, more fat, less water. How does that trio mess with how drugs behave in the body?
It changes everything pharmacokinetically. For lipophilic drugs, fat-loving drugs like our volatile anesthetics, many opioids, benzodiazepines, the volume of distribution, VDS, actually increases because there's more fat tissue for them to dissolve into. This can prolong their elimination half-life.
Okay, fat-soluble drugs stick around longer. What about water-soluble ones?
For hydrophilic drugs, water-loving drugs like some muscle relaxants, certain antibiotics, the volume of distribution decreases because there's less total body water to distribute into. This means if you give a standard IV bolus dose based on weight, you get a significantly higher initial plasma concentration. Higher peak, more risk of toxicity right at the start.
And this combination, higher surface area relative to mass, slower metabolism, also makes them incredibly vulnerable to getting cold, hypothermia. It seems more pronounced and lasts longer.
Oh, hypothermia is a really dangerous cycle in the elderly. It happens more easily due to dysfunction in the hypothalamus, the body's thermostat. Their lower BMR generating less heat and less effective peripheral vasoconstriction to conserve heat. And once they get cold, it triggers a cascade of problems. It slows down drug elimination even further, prolonging recovery. It significantly impairs blood clotting, increasing bleeding risk. It compromises immune function. It blunts the breathing response to CO2.
And the shivering.
And the shivering to generate heat is incredibly dangerous. It drastically increases oxygen consumption, sometimes by 400, 500%. In a patient with already limited cardiac reserve, that surge in oxygen demand can easily trigger myocardial ischemia or even infarction.
So waiting until they're cold to warm them is too late. Active warming needs to be aggressive and start early.
Absolutely. Prevention is the only acceptable standard here. Active warming needs to begin before the induction of anesthesia, preoperatively if possible, and continue aggressively throughout the entire case. We're talking fluid warmers, blood warmers, forced air warming blankets like the bear hugger, thermal mattresses, the works. High humidity in the OR can help too.
Okay, last system in this section, the central nervous system. We know there's physical loss, fewer neurons, shrinking brain volume, especially in the frontal lobes, less cerebrospinal fluid, reduced neurotransmitter activity. This must be why they're so sensitive to our anesthetic drugs.
It's the ultimate vulnerability at the receptor site, yes. All those changes, potentially including increased permeability of the blood-brain barrier, they result in dramatically increased sensitivity to pretty much all anesthetic agents.
Hmm.
And we can actually quantify this quite precisely for inhaled agents. The minimal alveolar concentration, or MAPC ton ISDAF, from my side, the concentration needed to prevent movement in 50% of patients decreases by roughly 6.7% per decade of age, starting from the value for a 40-year-old adult.
6.7% per decade. That demands a really calculated, careful approach to dosing gases.
Meticulous titration isn't optional, it's mandatory. For induction agents, IV agents, you often need to reduce the dose by up to 50% compared to a standard adult dose, maybe even more. They just have an exaggerated and prolonged response to anything that depresses the CNS hypnotics, opioids, benzodiazepines, and we really have to hammer this home. Follow the Beers criteria. Avoid benzodiazepines if at all possible, or use absolutely tiny titrated doses. They are major contributors to postoperative confusion, falls, and delirium. Huge risk.
Regional anesthesia often seems like a good alternative, maybe sparing some systemic effects, but even spinal or epidural techniques have age-related pitfalls, don't they?
They absolutely do. Anatomically, things like decreased disc height, narrowed spinal canal or foramina, arthritis, they can just make placing the needle technically more difficult. Physiologically, there seems to be increased permeability of the dura to local anesthetics. There's also an increase in the specific gravity of the CSF and a decrease in the total CSF volume. All of that together can lead to a more extensive, higher spread of the local anesthetic in the subarachnoid space after a spinal injection. So you generally need to reduce the dose of local anesthetic.
And their blunted heart response makes sympathectomy from a block more dangerous.
Precisely. When you do a spinal or epidural, you get that sympathetic block causing vasodilation. In an older patient with already impaired cardiac reflexes and maybe diastolic dysfunction, they are highly vulnerable to sudden severe hypotension that might not respond well to vasopressors. They can't compensate easily. And one more thing. That standard epinephrine test dose, we often add to epidural locals to check for intravenous injection. It's less reliable in the elderly. Why? Because their end organ adrenergic receptors are less responsive.
Wow.
They might not get that expected jump in heart rate even if the needle is in a vessel, giving you a false negative, a false sense of security.
We've established that this specialized assessment neurocognitive functional is non-negotiable. Let's dig into the specific tools the ACS, NSQIP, and AGS recommend. Starting with cognitive screening, getting that baseline.
Right. The strong recommendation is for routine preoperative neuropsychiatric screening. Why? To establish that crucial baseline. Because having pre-existing cognitive issues, even mild ones, is the single biggest risk factor for developing postoperative delirium later. And the preferred quick screen is the MiniCog.
The MiniCog, why that one?
Because it's fast, it's easy to administer, doesn't require special equipment, and importantly, it seems less biased by the patient's level of education compared to some other screens like the MMSE.
Okay, what does it involve?
It's simple, 2 parts. First, a 3-item word recall. You give them 3 unrelated words, distract them for a minute, then ask them to recall the words. Second part is the clock draw test. You ask them to draw a clock face, put in all the numbers, and then set the hands to a specific time, like say 10 past 11, 11:10.
And if they fail either part?
Failure on either the word recall or the clock draw indicates a positive screen. It means they need more in-depth neuropsychological testing before surgery, if possible, and flags them as high risk for POD.
Okay. Then there's establishing decision-making capacity. This is huge, legally and ethically, before getting consent. Let's say a patient agrees to surgery, but flat out refuses to accept that their severe, untreated heart failure makes recovery incredibly risky, maybe even fatal. Which legal criterion have they failed there? What happens next?
That patient has clearly failed the second critical criterion. The ability to appreciate their medical situation and the likely consequences of their choices, including the risks of not treating the heart failure or proceeding with surgery despite it. Remember the 4 legally relevant criteria for capacity. 1, can they understand the information about treatment options, risks, benefits? 2, can they appreciate how that information applies to their own situation? 3, can they use reasoning to weigh the options and make a choice? And 4, can they clearly communicate that choice?
So failing appreciation means?
Failing appreciation means their consent isn't truly informed, even if they say yes. The consent process has to stop. You need more discussion, maybe involve family, an ethics consult, or possibly even a formal capacity evaluation if needed, before proceeding with any non-emergency procedure.
Got it. Now, let's talk frailty. You mentioned it earlier. It sounds like this biological state of vulnerability, maybe even more predictive than just their ASA score.
Absolutely. Frailty is a measurable biological syndrome. It's defined as this state of increased vulnerability to stressors like surgery because of a decline across multiple physiological systems, leading to reduced homeostatic reserve. Think of it as dwindling resilience. We classify it broadly as primary frailty, which is just due to the intrinsic aging process itself, or secondary frailty, which is more like the end stage of a chronic illness. Severe COPD, advanced cancer, end-stage renal disease.
And screening is essential because it predicts bad outcomes.
It correlates very strongly with adverse outcomes. Falls, delirium, infections, longer hospital stays, discharge to nursing facilities instead of home, and increased mortality. That's why screening is now considered essential practice.
How do we actually measure or quantify frailty? What are the tools?
There are a couple of main approaches. Probably the most widely cited is the Fried Frailty Phenotype, or SCORE. It uses 5 specific physical criteria: unintentional weight loss, self-reported exhaustion, low physical activity level, slow walking speed, and weak grip strength. Having 3 or more makes you frail. Another approach is the Frailty Index. This looks at an accumulation of deficits over time, counting up diseases, symptoms, disabilities, even psychosocial factors. A higher number of deficits indicates greater frailty. The specific tool used might vary, but the key is doing the assessment to identify these high-risk patients who need extra support or pre-optimization before surgery.
And we can't talk frailty without talking nutrition, right? Malnutrition seems common and easily missed, fueling that downward spiral.
So common and so often overlooked. Malnutrition directly contributes to sarcopenia, worsens frailty, and is strongly linked to poor surgical outcomes, more complications, higher costs, increased risk of death.
What are the specific red flags, the hard criteria from ACS NSQIP that say this patient is at severe nutritional risk?
There are 3 key criteria. If a patient meets any single one of these, they are considered at severe nutritional risk and ideally need nutritional intervention, which might even mean delaying elective surgery for optimization. Okay, the criteria are: 1, a body mass index, BMI, below 18.5 kilometers squared. 2, a serum albumin level less than 3.0 grams per deciliter, but yet to make sure that's not just due to kidney or liver failure messing up albumin levels. And 3, significant unintentional weight loss, losing more than 10 to 15% of their body weight in the past 6 months.
Any one of those triggers the alarm.
Anyone. It signals impending problems with wound healing, immune function, and overall recovery unless you address the nutritional deficit.
Okay, next assessment. Functional status. This gives us that baseline for recovery goals, measured by ADLs, IADLs. But the quick, practical mobility test that really informs anesthetic planning seems to be the TUGT.
The Timed Up and Go test, or TUGT, it's incredibly useful and high yield for predicting risk. Simple. The patient starts sitting in the standard chair, stands up, walks 10 feet, about 3 meters, turns around, walks back to the chair, and sits down again. You time them.
And what's the magic number?
A time longer than 20 seconds is the critical threshold. Taking longer than 20 seconds is strongly predictive of a higher risk for falls, yes, but also significantly increased postoperative complications and even higher 1-year mortality after surgery.
So if their TGT is over 20 seconds, how does that change what an elite professional does with the anesthetic?
It absolutely must adjust the plan. It signals profound functional limitation. You should strongly favor anesthetic techniques that preserve their baseline mobility and function as much as possible. Maybe using regional anesthesia instead of deep general anesthesia if feasible. And you have to be extremely cautious and conservative with dosing any systemic sedatives or opioids that could worsen their mobility or cause confusion post-op. That TGT score really mandates a tailored, function-preserving approach.
Makes sense. Lastly in this section, the huge issue of polypharmacy. Taking 5 or more meds seems standard, but it's a minefield for adverse drug reactions, ADRs.
It's practically an epidemic in this population. 5 or more medications is the common definition, and it dramatically increases the risk for ADRs. This can be due to prescribing cascades, drug interactions, or just the increased sensitivity of the aging brain and body, combined with those pharmacokinetic changes we discussed.
And the tool to navigate this minefield is the Beers criteria.
Exactly. The American Geriatric Society's Beers criteria list provides explicit, evidence-based guidelines on potentially inappropriate medications, PIMs, that should generally be avoided or used with extreme caution in older adults due to their risks outweighing potential benefits in most cases. Reviewing the patient's med list against the Beers criteria is a fundamental safety check.
What are some key anesthetic-related adjustments specifically highlighted by Beers that we absolutely have to integrate into our practice?
Okay, some really critical ones for us. First, explicitly avoid meperidine, Demerol, for pain control. Its metabolite, noraperidine, accumulates, especially with renal impairment, and can cause seizures and CNS toxicity. Big no-no. Second, use benzodiazepines very cautiously, if at all. Minimal doses, short-acting agents if you must, but preferably avoided completely due to the high risk of prolonged sedation, confusion, falls, and contributing to delirium. Third, make sure essential medications, especially cardiac meds or others with withdrawal potential, are continued through the perioperative period unless there's a strong contraindication. Don't just stop everything. And fourth, critically, any drug that's cleared by the kidneys must have its dose adjusted based on the calculated estimated GFR, eGFR, not just based on that potentially misleading serum creatinine level. You have to account for that age-related decline in renal function.
Okay, let's pull together all these pharmacokinetic changes we've discussed. We've got less blood volume, more body fat, less total body water, and slower kidney and liver clearance. What's the net effect? What does this mean for that initial punch of an IV drug versus how long it sticks around?
It creates this really dangerous combination, you're right. The decreased blood volume means when you give an IV bolus, especially a water-soluble drug, it gets distributed into a smaller initial space. That leads to a higher initial peak plasma concentration.
So potentially faster onset, higher peak for hydrophilic drugs.
Right, and a higher immediate risk of toxicity from that peak. At the same time, you've got the fat-soluble lipophilic drugs having a larger volume of distribution because of the increased body fat, which can prolong their effects later on. And then you layer on top the reduced clearance by the kidneys and liver. The overall effect is often both an exaggerated initial impact and a significantly prolonged duration of action. The drugs hit harder and last longer.
So given that increased brain sensitivity and the prolonged effects, what are the practical recommended dose adjustments for common IV agents like propofol or opioids? Ballpark figures.
Yeah, the general rule is significant dose reduction and slow, careful titration. For agents like propofol and etomidate, both the initial bolus dose and any subsequent infusion rates often need to be decreased by up to 50% compared to a standard younger adult dose, sometimes even more based on frailty.
50% reduction for induction agents. What about opioids?
Similar caution, opioid bolus doses generally need to be reduced by about 50% as well. They're much more sensitive to the respiratory depressant effects.
And midazolam, versed, already on the bears list.
Midazolam, yeah, ideally avoided. If you feel you absolutely must use it, the recommendation is an even more drastic reduction, potentially 75% less than a standard dose, and giving it in tiny incremental amounts, watching the effect very closely. Meticulous titration isn't just good practice here, it's the absolute safety standard.
Okay, neuromuscular blockers, muscle relaxants. The onset time might be prolonged due to slow circulation, but the elimination seems like the bigger worry.
The elimination is definitely the primary concern. Yes, onset might take a bit longer to reach the neuromuscular junction, but most of our commonly used non-depolarizing muscle relaxants like rocuronium or vecuronium rely heavily on the liver for metabolism and/or the kidneys for excretion. In an older patient who already has age-related reductions in hepatic blood flow and GFR, and who very likely has other comorbidities affecting liver or kidney function because of multimorbidity, the duration of action of these drugs can become dangerously unpredictable and prolonged.
So if standard drugs like rocuronium carry that risk of prolonged paralysis, what's considered the safer choice, the go-to drug for the elite professional in this situation, and why?
The preferred agent, the one that bypasses these organ dependencies, is cisatracurium.
Cisatracurium, because of its metabolism.
Exactly. Cisatracurium is cleared primarily through Hoffman elimination, a spontaneous chemical breakdown in the plasma, and also by ester hydrolysis by plasma esterases. Critically, these processes are completely independent of liver or kidney function. This gives you a much more predictable offset and duration of action, regardless of the patient's organ function or comorbidities. The big risk we're trying to avoid is residual neuromuscular blockade at the end of the case. Having leftover muscle weakness when you extubate, combined with their baseline sarcopenia and weaker airway reflexes, dramatically increases the risk of postoperative respiratory failure, hypoxia, and aspiration. Cisatracurium helps minimize that risk.
That makes sense. Okay, finally, let's explicitly link all these physiological vulnerabilities back to the concept of multimorbidity. Remind us of the definition and just how common it is.
Sure. Multimorbidity is simply defined as having two or more chronic medical conditions simultaneously. And its prevalence really underscores why mastering geriatric care is so vital. In people aged 65 to 74, about 62% have multimorbidity. And for those 85 and older, it jumps to a staggering 81%. It's the absolute norm, not the exception, in the patients we're discussing.
81% of the 85-plus group. And what are the most frequent conditions piling up that we have to manage concurrently?
The most common ones you'll see are hypertension, that's present in about 58%, then high cholesterol in 45%, ischemic heart disease, coronary artery disease in about 31%. Arthritis is common, around 29%, and diabetes, about 28%. And crucially, having multiple conditions, multimorbidity, is intrinsically linked with being frail and is a very strong predictor of poor postoperative outcomes.
Does that increased risk play out the same way for planned elective surgeries versus emergency operations?
No, there's a critical difference. While any older patient with multimorbidity is at a higher relative risk for complications after an elective surgery compared to a younger, healthier patient, the risk escalates dramatically for emergency surgery. They have about a 30% higher absolute risk of postoperative complications and death, specifically when undergoing emergency procedures. That stark difference really highlights why proactive assessment, optimization, and anticipating problems before a crisis forces an emergency operation is so incredibly important.
Okay, with all this clinical complexity, the frailty, the multimorbidity, the heightened risk, applying ethical principles correctly becomes absolutely paramount. Can you quickly review the 4 core principles as they apply here, but maybe focus on where they often clash in the OR setting?
Sure, the 4 main principles are autonomy, the patient's right to self-determination and making their own choices; beneficence, our obligation as clinicians to act in the patient's best interest, to do good; non-maleficence, the duty to do no harm; and justice, ensuring fair treatment and allocation of resources. Now, the most frequent and acute ethical conflict we encounter in the perioperative setting with older adults revolves around the do-not-resuscitate DNR order during surgery.
Right, the conflict between wanting to save them from a reversible anesthetic complication versus respecting their stated wishes.
Exactly. On one hand, providers feel a strong pull from beneficence. Anesthetic or surgical complications like sudden cardiac arrest due to medication or bleeding are often immediately identifiable and potentially reversible with interventions like CPR, intubation, defibrillation. So the instinct is to suspend the DNR to allow those life-saving efforts. But doing that unilaterally completely overrides the patient's autonomy, their previously expressed wish to avoid resuscitation. We simply cannot impose treatment against their clearly stated directive. It creates a major ethical dilemma.
So, the informed consent discussion must specifically address resuscitation status for the surgical period. The ASA and AAA actually recommend specific alternatives to just suspend the DNR, right? What are those options?
Yes, this requires a specific documented conversation. There are generally 3 recommended approaches to discuss and agree upon before surgery. 1. Full suspension. The patient explicitly agrees to temporarily suspend their DNR order for the duration of the anesthesia and surgery, and usually for a defined immediate postoperative period, for example, 24 hours. They agree to accept all necessary resuscitative measures during this time. 2. Partial suspension or modification. This is really important and allows for nuance. The patient might agree to some interventions but refuse others. For example, they might say, okay, you can intubate me, give me emergency medications, defibrillate me if needed, but I do not want chest compressions. This requires very specific documentation of exactly what is permitted and what is forbidden. 3. Resuscitation guided by clinical judgment. Some patients might trust the clinical team to make decisions in the moment, guided by the specifics of the situation and the likelihood of reversibility, while still respecting the patient's overall values and goals of care. But even here, the conversation must happen beforehand to confirm this approach aligns with their wishes.
That clarity is crucial. Okay, shifting to postoperative neurologic problems. Let's start with postoperative delirium, POD. Acute, sudden onset, disturbingly common, especially after big surgeries like hip replacements or aortic procedures.
Extremely common and often terrifying for patients and families. POD is defined as this acute disturbance in attention, awareness, and cognition. It usually pops up within the first few days after surgery, though it can sometimes last for weeks. And age over 65 is far and away the biggest predisposing risk factor.
How does it look clinically? Is it always agitated confusion?
Not at all. The presentation varies widely. You can have the hyperactive form, agitated, restless, maybe pulling at lines, combative, that's often recognized. But you can also have the hypoactive form. The patient is quiet, lethargic, withdrawn, slow to respond. This form is insidious and very often missed or misdiagnosed simply as depression or being sleepy from meds. Or you can have a mixed picture, fluctuating between the 2 states. The incidence rates are shockingly high in vulnerable populations, anywhere from 9% up to 50% or even higher after major orthopedic or cardiac aortic surgery.
50%, wow. What are the main risk factors we screen for, besides just age?
Key risks to identify preoperatively include any pre-existing dementia or cognitive impairment. That's number one. Also, male gender, a history of alcohol abuse, underlying depression, poor functional status, like that slow TUGT score, a high ASA class, 3 or higher, longer duration of anesthesia, and importantly, exposure to certain medications perioperatively, especially anticholinergics and benzodiazepines.
Management seems heavily weighted towards prevention. But once delirium develops, what's the treatment strategy?
Prevention is absolutely key, identifying those high-risk patients beforehand. But once POD occurs, the approach is tiered. First and foremost, find and treat the underlying cause. Is it infection, hypoxia, electrolyte imbalance, pain, medication side effect? You have to aggressively investigate and fix the trigger. Second, implement multi-component non-pharmacologic interventions. This is crucial. Things like frequent reorientation, ensuring they have their glasses and hearing aids, maintaining a calm and quiet environment, especially at night, promoting normal sleep-wake cycles, encouraging early mobility.
And medications. When do things like Haldol come in?
Pharmacologic treatment, like low-dose haloperidol or sometimes lorazepam, is really reserved as a last resort, strictly for situations where severe agitation poses an immediate safety risk to the patient or staff. These drugs don't treat the underlying delirium, they just manage symptoms, and they can sometimes even worsen or prolong the cognitive disturbance. So used sparingly and only when necessary for safety.
Are there specific anesthetic techniques or strategies that seem to help reduce the risk of POD?
Yes, there's growing evidence supporting certain strategies. Maximizing the use of regional anesthesia techniques, both for the surgery itself and especially for postoperative pain control, like peripheral nerve blocks, seems beneficial, likely by reducing systemic opioid exposure. Avoiding those high-risk medications from the Beers list is critical. Using intraoperative EEG monitoring like BIS or other depth of anesthesia monitors to guide anesthetic depth and, crucially, avoid periods of excessive deep anesthesia or EEG suppression. Burst suppression is important. That suppression pattern itself is an independent risk factor for POD. And there's also promising data suggesting that using a perioperative infusion of dexmedetomidine, Precedex, might actually decrease the incidence of POD, possibly due to its more sleep-like sedation and lack of respiratory depression.
Okay, so that's POD acute, fluctuating. Now contrast that with postoperative cognitive dysfunction, POCD. How is it different in terms of onset, symptoms, diagnosis, and impact?
POCD is a much more subtle and insidious beast. Unlike the abrupt onset of delirium, POCD typically emerges weeks to months after surgery. It's characterized by more subtle cognitive deficits, problems with memory, difficulty concentrating, impaired comprehension, trouble with complex tasks. Diagnosis is also much harder. There are no universally agreed-upon diagnostic criteria, and making a diagnosis really requires formal, sophisticated neuropsychological testing both before surgery to get a baseline, and then again weeks or months after surgery to document a decline. It's not something you easily spot at the bedside.
And the impact can be devastating long-term.
Profoundly devastating. It can lead to an inability to return to work or previous levels of activity, a permanent decline in performing activities of daily living, loss of independence, and sometimes the need for long-term assisted care. It can really change the trajectory of someone's life after surgery.
What about risk factors? Is it just age again?
Advanced age is certainly the most consistently identified risk factor for POCD. Others that seem to play a role include lower educational level, perhaps less cognitive reserve to start with, longer duration of anesthesia, and evidence of some cognitive decline even before the surgery. But the picture is less clear than for POD.
What are the leading theories right now about what actually causes both POD and POCD? Is it the anesthesia itself, inflammation, something else?
It's almost certainly multifactorial, a combination of things interacting. But the main hypotheses center on maybe 3 key mechanisms. 1, cerebral hypoperfusion, episodes of significant low blood pressure during surgery or maybe microclots or emboli traveling to the brain. 2, systemic inflammation. The trauma of surgery itself triggers a body-wide inflammatory response. These inflammatory mediators can cross the blood-brain barrier, especially if it's more permeable with age, and induce neuroinflammation. 3, the direct effects of general anesthetics. Anesthetics themselves might contribute to that neuroinflammation or perhaps disrupt the delicate balance of neurotransmitters, and the aging brain theories often involve an excess of dopamine relative to a deficiency of acetylcholine. It's likely a complex interplay.
So, with POCD being hard to diagnose, having no known cure, and unclear causes, what's the bottom line for anesthetic management? What can we actually do?
Yeah, it's frustrating because there are no proven effective treatments or prevention strategies specifically for POCD right now. So the only viable approach is really meticulous risk minimization based on what we do know. This means being hypervigilant about identifying all the potential risk factors preoperatively, the frailty, the baseline cognition, the multimorbidity, and then tailoring the entire perioperative plan to avoid potential insults. That means maintaining stable hemodynamics, avoiding severe hypotension at all costs, ensuring optimal oxygenation, and trying to maintain stable cerebral perfusion throughout the entire anesthetic and recovery period. And, whenever feasible, favoring shorter, less invasive surgical procedures obviously helps by reducing the overall physiological stress and inflammatory burden on the patient. It's about minimizing all potential hits to an already vulnerable system.
Wow. This entire deep dive really drives home the sheer level of specialized knowledge and vigilance required to safely navigate surgery in this population. It's not just adjust the dose a bit.
It's not at all. It demands a truly individualized, comprehensive, and proactive strategy for every single patient. We've seen how decline in literally every organ system, from the mechanics of the stiff chest wall to that sneaky normal creatinine masking kidney failure, impacts every phase of care. The ultimate takeaway for you, the listener aiming for that elite level of practice, is that mastering this means you have to move beyond chronological age. You have to accurately quantify the patient's true biologic age and functional reserve using these specific evidence-based tools we've discussed. And you have to commit to working as part of a multidisciplinary team to optimize them before they hit the operating room door. That's what defines top-tier quality care in geriatrics.
Absolutely. And as we wrap up, looking ahead, given everything we've learned about the enhanced spread of local anesthetics in their nervous system and their extreme sensitivity to systemic drugs,
Yeah.
it really sparks a provocative thought for the future, doesn't it? How might surgical and anesthetic management evolve? Could we potentially leverage techniques like ultra-low dose systemic anesthesia, maybe sophisticated total intravenous anesthesia, TIVA, combined with highly targeted, highly localized regional nerve blocks to fundamentally reduce that systemic drug exposure and perhaps mitigate the neurocognitive risks like delirium and POCD, especially for our oldest, most vulnerable patients?
That's a fascinating question. Finding that optimal balance, minimizing systemic drug load while ensuring adequate anesthesia and analgesia through precision regional techniques and delicate balance is likely where the next major advancements in geriatric perioperative safety will come from. It will definitely shape the next decade of care.